Good afternoon, and welcome to Value-Based Care Transformation Journal, a webinar tweet chat combo from healthsystemCIO.com, sponsored by Mirth, a NextGen healthcare solution. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemCIO.com, and I'll be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. If you have any questions that occur to you, type them in, send them in, leave the default set to all panelists. We'll take them later in the programming, but again, you can send them in as they occur to you. And you can download the deck using the URL on your screen. It'll be sent out in the chat box, and it's also at the bottom of our slides. Just so you see how we're going to spend our time today, first we're going to hear from Renee Broadbent, AVP, Population Health Information Technology and Strategy with UMass Memorial Healthcare. Then we're going to hear from Bruno Nardone, SVP of Solutions, Population Health at NextGen Healthcare. And then we'll have our Q&A. So without further delay, we're going to turn it over to Renee Broadbent. Renee, thanks for joining us today.
Thank you very much for having me today, Anthony, and I'm very excited to participate in this webinar with my colleague Bruno and talk a little bit about how we're transforming to true population health at UMass Memorial. So this is just a small agenda. These are some of the topics that I'll be covering. You've obviously know who I am as the speaker, so we don't need to go into that. But these are some of the basic issues that we'll be talking about that help us set up our framework for population health and value-based care. So a little bit of an overview of UMass. We are the largest healthcare system in Central Mass. We are a clinical partner with the medical school, and we have access to the latest technology, clinical trials, and research. We have multiple locations. We're a fairly large health system. In Worcester, we have our main campus, Clinton Hospital in Clinton, Health Alliance, which serves our Leominster and Fitchburg area, Marlborough Hospital in the Marlborough area. We have a large physician staff of 1,600, 3,000 registered nurses, 12,000 total employees, and 1,125 hospital beds throughout our health system. So to begin today, I'd like to talk a little bit about what is the definition of value-based care. And it's described as the transformation from a fee-for-service model to one that provides reimbursement, time payment for quality to the delivery of care, often referred to as shifting from volume to value. I think it's really important when you're talking about population health and the transition to value-based care is to level set with the definition so that you have everybody has the same understanding of what we're talking about in terms of when we say value-based care and population health. So I kind of like this cartoon because it sort of encapsulates what we're talking about, right? So in our world that we sort of exist in now, because we're half in each world right now, we're going to run some tests to help pay off the machine. That's our normal way of thinking, right? How many tests can we do in order to pay things off versus how can we deliver high-quality care while reducing costs? Hang on one second. I'm a little trouble with my mouse there. So one of the things I want to talk about is we're going to set up the framework today for a series of things that we're doing to build out our program. And so what I'd like to focus on is what we've accomplished so far. So in our program, in the Office of Clinical Integration, which drives our population health management program, we've created a pod leader structure and physician engagement enables. So we have a fairly sophisticated pod structure, and I'll go into a little bit more into that later. Care management with a longitudinal care process. We've implemented patient ping, which connects us to our preferred SNFs. We've implemented Salesforce, which is our CRM, how we tie all of our physician practices together. We went through an extensive process and selected Mirth as our data aggregator, who is going to automate our data collection, and we'll get a little bit more into why that was important. We've created key predictive analytics. We are in a Medicaid ACO pilot, so for those in Massachusetts, there were 6 locations picked to pilot a Medicaid ACO. We were one of them. And we are participating in the development of Healthy Planet and plan on integrating it in our population health strategy when EPIC goes live on 10/1. And here's how we did it. So we have a customer-focused and dedicated team called the Office of Clinical Integration. It has its own leadership team, which I'm a part of. We have data analytics staff, we have physician leadership, we have practice improvement and redesign teams. Those are folks that actually help our physician practices improve their workflows and understand what their quality reports are and really help them through the process. So for example, during GPRO reporting time, if you're an ACO participant. We have an information technology infrastructure, so we have dedicated folks that participate in the information technology pieces of it and aligned with the larger strategy for information technology. And we have care managers who participate with our Medicare and Medicaid programs. The practice improvement facilitators, they are practice resource levels. So those are the folks that are out in the fields with our clinical practices. And it's really important to understand that we have a very large network for UMass, and about 50% of the folks that we serve are independents and outside of our network, meaning they're not going to be on the Epic system. So that's important to know as when we get into the data aggregations discussion. We have outreach support. We help patients we help our practices contact patients to make sure they're showing up for their visits, and we provide that as a value add. Care management, program operations, we have folks that are dedicated just to supporting all the operational needs for participating in one of our programs, in which we have several. So there's a total of about 45 FTEs supporting population health efforts, and that number continues to grow. When I first joined the organization, there were 15, and now we're up to 45, and we have the full executive support of our organization. So when we talk about transitioning to value-based care, we want to talk about the different things that are involved in it: demand for services, new sites, reform, technologies, competition. You know, the lines are blurred now where people can go get health care. It's not an easy process, and it's not an overnight process. You know, there's no switch that says, oh, here we are. It's transitional over time. Key things that are important is having support from the most senior level teams. So it is in our mission statement. It is in our vision for the organization to have population health. So that's really key if you're going to be successful. It's got to be at the system level. You can't have one-offs and pockets of folks doing things. As time goes on, to make the shift, you have to have an increasing appetite for risk. It is not an easy process, as I mentioned. It's complicated by changing regulatory landscape, administrative change. There's a lot of uncertainty with it, so you've really got to be a solid team to move this forward. But you can do it. It's not cookie cutter, but there are basic foundations and principles that will help guide you through it. So one of the first things I want to talk about is physician engagement. How do you do this? This is exactly what you're going to see, right? So physicians, this is a hard transition. This is a big load on them. And you have physicians that probably won't make this transition because they're getting ready to retire. And then you have physicians on the other spectrum who are coming out of school that are more acclimated to it. But the biggest thing of this is to try to pull your physicians together and create that network and create that engagement. So what we did is, under the guise and under the leadership of our clinical partner, Dr. Thomas Skornavaca, he is our Chief Medical Officer, Senior Director of Medicine, who is also a practicing physician, and that's really key, that there's somebody that's still boots on the ground and understands the position of the physicians in. So we created this pod structure. We have regular meetings. We provide services to them. We help them develop metrics. We help manage them. We provide the PIP services to them. So we are a full-scale service provider to them to help them through this transition. And right now, our organization is fairly large. We have about 35 pods with designated leaders. So the pods are groups located by area, and then there's a leader within that. And there's regular educational forums and things like that we do to them. And our managed care group has about 150 primary care practices of all practice types. And each of these, we reference the PIF, each of the pods has a PIF assigned to it to help them with these things. And before we organized the population health drivers, right, we had about 16 or 17 committees that were driving all of this. Well, that's not certainly efficient, and it's always the same people that were always on those committees, so they were just meeting down and not being really effective. So we went through a process and built a structure that could still deliver the things that were critical to population health, such as quality improvement, utilization care management, the pod leaders, and having finance operations and compliance. So those are all sorts of key components that we support in our office, and we've streamlined it to deliver this efficiently and manage the organization. In addition to engaging your physicians, you also have to have some level of incentive to get them to do this. I mean, that's what docs, they're trying to run their business, they're trying to do this. So we have to create that incentive. So we collaborated with our managed care network and we crafted this incentive plan to drive improvement in the quality scores, because that's key to this process. They all get a practice level score. It's based on commercial and governmental. The higher the score, the higher the amount. We made it super simple, but review for unintended consequences, so we have an audit component to it. Potential improvement drives performance. And there's a staff competition. So, the people that are in the clinical practices are really doing a lot of this work, so we actually incentivize them to help the physician, to help empower them to move this forward. And you can see from the volume to TME to go down and improve the incentives to go up. So we rise and fall together. It's really critical that we have the integration between the specialists and the PCPs. Transitions of care are key from one location to another, to a SNF, et cetera. We want high quality value care. We focus on prevention, not after the fact. We make the assumption that nobody can manage this from a physician practice alone. That's why we provide the support. We are supportive in our processes. We help you with your practice redesign and workflows for the entire system. Transparent performance reporting steers the ship, so we give them reports that are actionable and deliverable and actually that they can understand and aren't overwhelming. And that is supported by a robust technology platform. And it's all about the data. So what we try to do is make the data as actionable as possible for them, accurate, point-of-care reminders, monthly patient registries, progress reports. All of those things are delivered to these people. All of this is facilitated through that prod structure and the PIPs doing these types of things. So it's a very nurturing, very supportive environment to help the physician transition through this. And in turn, we create a supportive, strong network. So I'll talk a little bit about our other pillar, which is care management and patient engagement. So here's what we do to facilitate some of the care management efforts. We focus on the beneficiaries with high hospitalization and readmission, the primary care practices with significant volume of high-risk patients, and so we're working with them constantly to manage this. Preferred skilled nursing facilities, we have created a preferred SNF network that our patients would be discharged to. We have a group of folks that work directly with them. We have developed criteria for those SNFs to participate in this, and actually it's had a really interesting effect because now we have SNFs who want to get involved and establish the criteria so they can participate. We've created workflows, we've created care plans and things like that for those particular facilities to help us in this process. We actually have spring and fall meetings with them. We have a post-acute group that meets with them, and we've provided some technology for care management, which is always a little tricky because our care managers in the population health world work on many different systems, so they have to be pretty agile. But we have patient pings, which helps notify us when patients are admitted. We have a care management tracking database which tracks a number of different things. And we have the EMR ACO care management task team, which actually looks at optimizing our EMRs to help us manage care management. And in addition, which isn't included on this slide, of late we have now deployed mobile technology with our care managers. Now, mobile technology in and of itself isn't new, but the idea that you create this kit for a care manager who may be in a patient's home, who may be in a facility that doesn't have Wi-Fi, but can get in and answer the question to a patient that says, I don't remember what my med list is, and can do that right at the site for the patient, enhances the care even more. So technology continuing to help enable that process. We've also launched a longitudinal care model, and that is what happens before and after, and how do you encompass all of that. One of the things that we found is a lot of our members and beneficiaries and patients seek alternate care or get where's that network of other support services. So very commonly, things like the YMCA, they have things like that. So we're in the process now of embarking with putting this longitudinal care model together for not only the services, but a technology to tie it all together to get those services, to share those services. So that is one other aspect of the care model. And in order to get this and have it be effective, you have to choose a population where we have data, right? So a rich data set helps you manage that. Some of that we're looking at, it's the ACO beneficiaries, high risk, our self-insured, so those are our employee base. And we evaluate our current work to build off of what's already going on. We start with small goals and follow the patient through the entire care loop and expand on what we learn, and identify starting chronic disease targets. So there's a whole process and a team that works on that and continues to evolve this program. And you know what? There are ways to make immediate impact, and people think you have to get really elaborate, but you don't. This is one way to just really start to focus on small areas and then expand out. Align care management model with a shared platform, give alerts, notify the patient location and status. That's huge. That really gives people the opportunity to act. Intervention at each touch point, and awareness of enrollment in other programs. So where are those patients enrolled? What other services are they getting, and how can we tie that all together? Reconnect to care when a patient falls off the grid. So that's your group that you were treating, and somehow they're no longer there. Stay in touch with them. And hand off to patient as they move through the system. Provide them some guidance. You know, oftentimes our healthcare is extremely complicated, very hard to navigate through, and so providing those services to help them navigate through that process is critical to the success. We also do patient outreach, and so this is just some statistics of the number of contacts and the calls that we do. This is to remind the patients, you know, where they have to be, what they have to do, so that they don't miss those critical things like testing for A1C. So I'm going to move to another component. So we've talked a little bit about the network, the docs, how we engage them and support them as one component. We talked about care management as another component, which is big. And now we want to talk about the data analytics and the infrastructure. This is our visual framework for value-based care and population health management. So I always like a visual because I think a picture tells 1,000 words. And I like to think of this as a house. All right, and at the base of your house, you don't build it from the roof down, you build it from the bottom up because you need a good foundation, right? And the base of a good foundation for value-based care and population health is your information technology and your data infrastructure. So what data do you need, where you're getting it, what is the quality of the data, how are you using it? And if you look up, it builds financial strength and capital formation and supports each of the pillars, growth and positioning, clinical integration, and value strategy. And so each of those pillars has more granular detail below them, but this is the framework of things you need to focus on, and it's a snapshot of the strategy. And the information technology piece, even though it's the foundation and it's one line, that could be comprised of many components. So what do we focus on for our value proposition? A local, fully integrated delivery system of quality and cost-integrated network, a consumer-driven approach to delivering exceptional care, robust longitudinal care management, infrastructure to provide quality reporting and data analytics, and strong community presence with linkages to local community-based services, all tied together through technology. And this is just our plan internally for our organization. So if you look, it goes through 2018, which means I'll probably be updating it sometimes through. And if you look to the left hand, it has care management, reporting and analytics, business systems and programs. So the programs are the tools that you're using to migrate to value-based care, whether it's an ACO, whether it's a PCPR program, which is specific to Massachusetts, whether it's a Medicaid pilot, whether it's a Medicare Advantage plan, whether it's self-insured. There's a continuum of these programs that you build together and create momentum for delivering value-based care. And then you talk about the different tools and things that you have to do in order to aggregate that data, in order to use it meaningfully, and then your care management. So this is our timeline. This is my one snapshot. And I evolve this as time goes on, and some of these are accomplished or we add into our direction. And we engaged a year or so ago with an organization to help us define that strategy. So I want to be clear on one thing. A lot of people think this is easy to go alone. We don't feel that way. We feel as though we want to leverage the power of those that are outside the organization, that are exposed nationally, that can help us consolidate what we want to offer here. So we came up with our basic value prop, and these are the areas, as you'll see, and you'll see it reflected in my timeline, you'll see it reflected throughout sites. These are the areas that we focus on in order to develop our program. And from that, we came up with our conceptual model of the data and what it's used for. So in the very left, you'll see data aggregation, and it's payers, it's our EMRs, it's wherever data comes from external sources. And then it's the preparation of data, and then how it feeds, all right, into the different functional areas, such as care management, reporting and analytics. And that's what fuels value-based care. That's what you really have to try to get your hands around, because there's a lot of data out there, and data analytics are really powering how that organization is going to look and manage their populations. So some information on us. This is our geographic spread. So you can see this is the state of Massachusetts. Our primary service area is in the middle, but we do have pockets to the east and to the west of us. We manage about 190,000 members in various programs, so we really need robust technology to help us do that. So what is our strategy? Implementing a data aggregation strategy. So part of our analysis was who's a partner that can help us do that, and we selected Mirth as that partner to help us. They have a great tool. It's the thing that's one of the best things about it is that it's agnostic to EMRs. It's worked with all of them. There's a lot of advantages to it, and we need that because we have 42 different EMRs. Half of our population that we manage and our providers sit outside the UMass framework based on our ACO and our other independent networks. So we need something that can collect all that information. It's going to aggregate all of our data and all of our other additional data sources as we evolve this project. We're also leveraging Epic. We are about to go live with all of our health system on 10/1. We are going to optimize this to fully leverage Healthy Planet to continue to support our interoperability efforts, and we will start to engage how that data that we collect from Mirth works with Epic and how we create this really rich data set. We will also be leveraging Community Connect, Epic Care Link, and Care Everywhere. What our goal is to create that interoperable framework because that will create that ecosystem that we need of data and information to manage our patients and our populations and provide them the best care and direction that we can. We've developed an IT plan for integration and migration plan to the hospital EMR. You know, how do those pieces, what is that going to look like for us? We've developed enhanced reporting and predictive analytics, actionable data for future planning and data governance, strategic enterprise analytics driven by population health and value-based care. So what that means is we've started to embark down what are our plans for 2018 beyond. So we're setting the table now for the data analytics framework and how we're going to build that out and manage it not only for the health system, but how that all integrates to the school so that we can create this very rich set of data that we can use for research and management. And we're starting down that road with the right governance framework. And one thing you need to kind of evaluate too is what other systems are needed to support population health, right? So we have a specific organization that manages this for the health system. So what other tools are important for the organization and that to help support it? And so we leverage SharePoint extensively, and we also use CRM Salesforce to manage our network. So when you're looking at your value-based strategy and your population health strategy, think of what the tools are that you have, where your gaps are, and how to leverage them. Because for value-based care and population health, because it's such a moving space right now, one system isn't going to do everything. 20 systems will leave a lot of confusion, but there's a good mix in the middle that will help you get to that point. So again, not for tools for value-based care, it's not one, but it's not 20 either. So the next couple of screens will just show you some of the reports that we provide to our organization and to our providers. These are actual reports with names redacted out of them. These are reports that we generate off the data that we collect, the data we aggregate from claims from EMRs, and then we produce these reports. We try to consolidate things so that it's one-stop shopping. And if there's, any folks on the line who deal extensively with physicians like I do, if you give them 20 pages of a report, they're not going to look at it. So we need something that can actually show them what they do, how they're doing, how they're comparing things to their peers, and where's some opportunities for improvement. And we provide the services to go over these reports then, and we're providing the technology to push these reports out to them. And this is a GPRO report. This is pretty much public information because the ACO has already reported on the GPRO, but this is the kind of thing that we gather and report to them on them, which really kind of gives them some really interesting information to see how they're doing against the GPRO. We also provide EMR guides and health flow sheets. So what you're seeing now is information that we've developed in our current technology to help with the clinical practices, specifically our own physicians, because they are all on the same system. We have similar functions that we'll be developing for our external physicians, and we also provide our external providers. We also provide them some like-type things to help them manage their populations as well. So the tidal wave has finally arrived. Did we miss the boat? And oh crap, was that today? No, we don't think so. I think sometimes there's a common perception out in the market that it's too late to get on board, it's too late to do things. However, that's not the case. It's never too late to start. There are fully about, if you look at some market industry statistics, about half of any organization polled, it started down this journey. And so if you're somewhere in there, you're not too far behind. But we think we've started on a good journey. We think we've got a lot of value add, and we continue to evolve that process. So what are your key takeaways? What are some keys to success that anybody can execute? Make sure you get physician leadership on board before your network. The physician alignment is key to this engagement. You know, we can talk about the technology, which was huge and important, but you got to have your docs on board. It's really important. Population health strategy before investing heavily in technology, which is always hard for me to say because I'm a CIO by trade, and I love technology, but you know what? The last thing a CIO wants is to have a million systems doing overlap technology and interfaces. So have a clear strategy in mind before you start to evaluate what tools will actually work for you. We took a long time to identify the correct aggregation tool, and we think it's the right strategy for us for where we're going in the long term. A transition plan for compensation and alignment of incentives to productivity. Again, going back to the physician alignment, you know, you've got to create that process. Organizational alignment around population health prevents silos. So if you come from a large integrated organization, you need to create a synergy and a strategy at a system level, not necessarily individual pieces doing their own thing, because then you just have a fractured approach. And you want to create an alignment of your inpatient and outpatient care management because they are so intricately related, they can't be thought of in boxes, one's over here and one's over here. You really have to integrate the entire strategy for care management for the patient's benefit. And change is good, and you go first. And with that, I'll turn that back to Anthony.
All right, Renee, thank you so much for that excellent presentation, and we're looking forward to getting in a little Q&A. So if you've got questions, send them in, and we will take them in a little bit. But first, we're going to hear from Bruno Nardone, who is with Mirth, a NextGen healthcare solution. Bruno, thanks for joining us.
Yeah, thank you, Anthony. Thank you across the audience, and your comments were fantastic, Renee. So I think that I'm going to be reinforcing some of the themes that Renee set out in her half of the presentation, and so I'll probably be able to move through a couple of these a little bit faster, but that'll leave more time for discussion or questions afterward. So as Anthony mentioned, my name is Bruno Nardone. I do have responsibility for all of our population health management solutions across NextGen. A part of that includes Mirth, and I'll talk a little bit more about that. Let's see, is it advancing? Anthony, do I have the ball? There we go. Okay, so because we're a publicly traded company, I do have to just float the safe harbor provision statement here for you all. So anything I say and do here that's forward-looking, please take as just that. And any decisions you make to invest in NextGen, of course, up to you, but don't base them on this discussion. A little bit, just a quick level set on my background. I said where my responsibilities are. I've been in the healthcare industry my whole career now, well over 25 years. And in my roles, I've served as an executive in health IT companies, but also as a strategy consultant in healthcare, working with payers and providers, with government entities. And my roots are that I started my career as a hospital administrator and was an administrator for about 7 years in the New York metropolitan area. So I say that to let you know that I really understand and come from the perspective of thinking about how to help health systems meet their mission to deliver the best services they can to their constituents, to their patients. And so at the end of the day, I still think of myself that way, and I think that buys me some credibility as I talk to our clients. But in my role on the commercial side in consulting and with solutions companies, I've had the fortune to be working in this transformation space of helping organizations realize the benefit of connected health solutions for a number of years, working with organizations like the eHealth Initiative and Bridges to Excellence, Patient-Centered Primary Care Collaborative, around efforts to help move our focus away from point-of-care healthcare to really thinking about caring for patients across a continuum of care. And so I also bring that perspective to how I help drive solution strategy within our corporation, and I say that as a grounding for where my perspectives come from. So one more just kind of level set slide about NextGen. Mirth, as Anthony mentioned, is a part of NextGen, a larger corporate umbrella. And NextGen, as some of you may know, also offers EMR products and other solution tools specific, for example, to the dental marketplace. And we support large public HIEs with our Mirth products. Some of our Mirth components are actually in the public sector as tools that you can pick up free of charge and use as integration engines, for example. But we have over 7,000 clients representing more than 90,000 plus providers, and we do support some of the country's largest HIE implementations at the statewide level or regional level, and as well support many corporate entities with their needs for private HIE capabilities, which is how we were introduced to UMass originally. So this is really, it's a great honor to be in this shared presentation with Renee, and I'm really excited about where the market's going in this space. I'll tell you a little bit more why. We've sort of touched on this in Renee's comments earlier, but we too see the disruptive forces impacting the industry. What's exciting to us is the way that they are acting as a forcing factor for a shift to value-based reimbursement models. And you probably all could insert your own favorite slices of this pie, but you can see some of the things that we called out around the importance of connectivity and having the right infrastructure to manage information as we start to think about continuity of care models that really touch very disparate places that the patient touches as they move through the health system, and that those organizations typically have a myriad of health information technology components that they're collecting information on those encounters, and the way that they share that information, the approach to interoperability is, of course, a little bit different. And so that's number one here. As we move around the circle, things that we're focusing in on are, of course, heightened security and a scrutiny on quality outcomes in the value-based world, which we think is great, but it puts new demands on the market in terms of the systems they're using to capture information to support reporting on, but also managing to these new measures. The broadening of the continuum of care, as we've had a couple of comments on already, where we've seen a lot of incentives now from HHS and from private payers to pull organizations into thinking about how they care for patients over those multiple touch points, and including creating new payment models either through bundled payments or other payment incentive plans that really ask organizations to take responsibility for specific risk cohorts, especially as they move through multiple touch points in the system. And where those multiple touch points exist within one common enterprise, it might be a little bit easier, but in many cases, these patients are being cared for by by providers where the relationship across those touch points isn't necessarily as tightly governed. And so you have virtual models for caring for patients across a continuum of care that are now emerging. And we know that organizations are going to need advanced infrastructure to manage in those ways. Interestingly also is, of course, the changing demographics. You guys on this call are well aware of it, but it's something that we follow and monitor in terms of how we tune our solutions to support what our clients need. The heightening focus on cost, of course, not just from a containment sake of keeping costs down and lowering the cost of inflation around healthcare, but also thinking about how do we free up resources to now put toward impacting more or having a greater impact on outcomes that we desire. So allowing us to free up resources to do new and exciting things that support this shift to value-based care. And another factor that we're also very aware of is that there is accelerating industry consolidation. So more and more physicians are choosing to move to more of a corporate model for their own practice. And in that context, we know that the demands for complex system management are going to increase. And so how do our solutions need to support those shifts as well in our client base? So again, I'm sure that you might have one or two things here that you think are really key for managing through the shift. In the center of the circle here, you could see that we call out macro, we call out CMS's call to action to shift most of its payments to alternative payment models, 50% by 2018, with a plan to move more aggressively after that. So we know that this shift in the marketplace is only going to pick up more and more speed over the coming years. And the way we're sort of seeing that evolution for our clients is that, and this tracks along with a lot of what Renee was saying, is that first and foremost, we need to improve information visibility and giving organizations the ability to aggregate, manage, and have confidence in the data they're using to then drive more advanced service capabilities. Next is to optimize revenue and a lower total cost of ownership. And again, to free up resources to invest in new capabilities and then drive new even human resources to manage those new capabilities going forward as they sign up for more value-based contracts. To the right of these bars, you could see that we're looking at our portfolio of offerings, things like revenue cycle management tools, our EDI tools for how do we exchange data now with the current commercial payers or government payers that we know have valuable information coming from claims to complement clinical data. From a total cost of ownership perspective, how should we be thinking about the cloud as a way to lower our cost of ownership that we can then transfer to our clients so that they too can do more with sort of the same pie, if you would, of resources, and on up through increased patient intimacy, where we drive better patient engagement, and certainly our portals within the Mirth solution stack, as well as our NextGen patient portal, support those things. And then what happens to really empower those list of feature capabilities or functionality that Renee mentioned earlier that allow us to more effectively manage the patients that we identify as highest risk, right? All of that infrastructure is really exciting, but if we don't really put the new capabilities in the hands of those care managers or providers that are impacting the direct care of patients when they're interfacing with them, it's really all lost or, for naught. And so tools to provide the alerts, to provide the visibility, to provide information on where there are gaps in care around from defined best practice protocols is what we ultimately want to enable. So we talked about definitions and level setting and vernacular. Not surprisingly, when I do these talks, similar to Renee, I try to do the same thing so we don't have to spend time there. I'll tell you that our definition was very similar. But from an internal vision and mission perspective, the way we think about it is our job around enabling population health management to support value-based care is by supporting the needs of the industry to optimize care and well-being while optimizing the resources required to achieve those desired outcomes. And our mission as a corporation is to provide the tools and technology to support that shift. So again, a lot of similarities to what we've talked about. The way we think about a comprehensive capability suite to support value-based care is to first and foremost provide an infrastructure for aggregating information, again, reinforcing themes here, then to next analyze that information from a population health analytics perspective to identify where to prioritize our resources to have the greatest impact on our patients. Next, to provide the tools to those care coordinators and others along the care team that are going to be impacting the patient and need to see where they can have the best impact, where there are gaps that need to be addressed, who falls into cohorts of interest. But another dimension, and again, you know, sort of I saw this on the roadmap for UMass definitely, was to provide those administrative and financial analytics capabilities that allow you to then manage your own performance against the contracts you've signed up for. And then lastly, around engagement, patient and clinical engagement as well, where around patients, how are we empowering them to be more successful with their own care? And that comes from a number of things, but you know, you could think about your traditional patient portals on steroids, if you would, where we're providing insights and information about how to securely communicate with their care team, find information about their conditions, and so forth. But then on the clinical engagement side, providing insights so that, you know, this is to Renee's last slide about, you know, sort of let change happen someplace else first, and then let me know how it goes. We need to help educate our clinical staff so that they know why we're doing this. They know how we're not just layering new requirements onto them, but really re-engineering things to ideally let them, you know, take things off their plate that they don't need to be doing, that others could be managing more effectively, and let them focus on what's most critical for them to apply their skills and talents toward. Let them understand what tools are going to be available to them. And that takes, you know, some engagement there as well so that they come on board and can optimize the value that's available to them. The way we think about the component relationship here is in the context of a foundation layer that first starts with getting control over that information and applying analytics to it to deliver insights around populations at risk. And then we could do those value enablement capabilities after we've got that solid foundation. What I think is interesting that we should all be aware of is that, you know, there are traditional data sources that we're going to start out with, this information at the bottom of the screen, but just as Renee pointed out, that they're having now regular touch points with a preferred network of skilled nursing facilities, there are going to be a lot of non-traditional data sources that we're going to have to be aware of, going to be managing to, that we're going to want to feed into the algorithms that drive our analytics going forward, because they provide really important insights into how patients will be successful with managing to new care guidelines. So, you know, it might be those passive and active remote monitoring tools. It might be a telehealth service that we want to interact with because it's really popular with a large employer in our catchment area. Or it might be things like folding in credit reports, because we know that from a social empowerment perspective, a patient's financial status is as important in terms of their ability to manage care as is their laboratory profile. So all these things are going to come together in the brave new world around population health analytics that we're really excited about providing support for. The way we sort of advise clients at the highest of levels is to really think hard about your roadmap in the context of, first, the vision you've defined for your organization from a value-based perspective, determining where your priorities are, because you got to start someplace, and you want to be able to let success drive success. So thinking about, where you could get traction quickly to get other constituents in your organization excited about moving forward, and then having this really tightly defined roadmap so that everyone knows where they fit along the transformation continuum, and that they can get on board and get excited about what's happening to them, when and why. And the last piece I think is most critical, and where I'm going to end my comments today, is to be sure that when we're executing the roadmap, we really commit realistic resources to achieving those goals. We're transforming health systems that, don't move quickly, as we all know, and will require a lot of support to, get to the other side of this transition from fee-for-service to fee-for-value, and we need to make sure that we're committing realistic resources to get there. So with that, I hope that you get a better sense of how, from the vendor community perspective, we're tracking along with these changes, and I'm really delighted, always when I get a chance to work collaboratively with our clients and when we can help them and facilitate their transformation as well. So happy to take questions, and Anthony, I guess we'll turn it back to you for facilitating this, but thank you all for your time this afternoon.
All right, very good. Thank you for that presentation, Bruno. We appreciate it. All right, so now we have a few minutes for some Q&A, so go ahead, as I mentioned, type them into the Q&A box, leave the default set to all panelists, and we will take a look. Renee, a question has come in for you. Have you had challenges attributing patients to physicians?
Well, I think if you're talking in general with the ACO from CMS, that it's their attribution process is difficult. And so I think that that's a common problem for everybody. So what happens is because the attribution process happens at the frequency that it does, based on where people are discharged or what was on the record and what's on the claim file, sometimes patients are attributed to your ACO, then they're out of your ACO, and then sometimes you'll see other patients come into your ACO. So where that can have impact is, when you're calculating your, if you're going to have shared savings, sometimes what happens is all of a sudden you get a bunch of patients into your ACO, which throws all your numbers off, right? So yes, that is a challenge that continues to happen with the CMS model. And it's some of the newer, just if you stay with the track 1 models, some of the newer models have prospective attribution. There are other things that come with that because there's more risk involved in those models. But one of the attractive things on some of those is the prospective attribution. So whatever you have is what you keep throughout the process.
Bruno, any thoughts on attributing patients to physicians?
Yeah, there's no question that it can be a challenge. And a lot of times, what you'll find is your systems are perfectly tuned to ingest information about attribution, but it does take some coaching and re-engineering on the data collection side in terms of how information is collected around different touch points in the care continuum to make sure that we're putting appropriate information into the systems at the very kind of front end of the process so that the appropriate, we're not using an aggregate provider ID, but we're actually, using more granular specific provider IDs for documenting encounters as they're taking place, for documenting resources used around those encounters. And so it takes some, old-fashioned, process redesign work, staff education work to make sure that they understand the impact of their inputs downstream to accomplishing the goals of the organization, and how those, sort of fundamental inputs really can make the difference between an organization, a group, a health system meeting its incentive payments to line up with the contract requirements that they're providing. So it really is it's a classic combination of both systems and people achieving these goals.
Very good. Bruno, I'm going to wind up just to ask you one more question, and I think we're going to be out of time. You go into multiple health systems for different engagements. Is there any sort of, when you come in to evaluate the situation, is there any common sort of error in direction or the way they're going that you're seeing over and over again that you could help our audience avoid?
Yeah, well, it starts by not choosing Mirth products.
Of course. Of course. I mean, that's number one. But what would number two be?
No, obviously that's tongue-in-cheek. But, I'll go back to the sort of my wrap-up slide, and that comes to the first couple of bullets around, first and foremost, defining a clear vision. This transformation stuff is complicated, right? I mean, we are a complex industry, and we're transforming a complex industry that has incredible momentum built into it for the status quo. We've invested many, many years building infrastructure around being successful at fee-for-service. Now we're trying to, turn the battleship And without a clear vision and leadership communicating that clear vision on a regular basis, it's easy for us to want to slip back to our comfortable place of, well, we did things like this yesterday and it was all good. I'm comfortable there. So, you know, defining that vision, communicating that vision are key. And even in market-leading organizations, it's a struggle because life gets in the way. We have fires in our organizations all the time that require our attention. We have resource constraints. We have all kinds of challenges with our, you know, constituents and communities and regulations that we have to deal with. So having dedicated resources to managing that and, you know, sort of our resources that manage the project plans to deliver the transformation are really, I think, where people tend to underappreciate, underinvest in what it's going to take to get there. And we hear it all the time. Wow, I wish I would have put more against process redesign. I wish I would have put more in, staff around communicating to our constituents. So I would say that those are the big areas that we need to make sure we cover, and where we see even, you know, sort of leading organizations around the country going back and reassessing what they'll need to be successful.
Very good. Well, that's about all we had time for today. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could take a moment to answer that, we'd appreciate it. Regarding continuing education, for those of you who hold the CHIME CHCIO certification, attending our webinars gets you 1 CEU. Please let CHIME know you were here, and if you've asked us to do so, we will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when this event has been posted to our YouTube channel. If you'd like us to produce a webinar for you, you can contact Nancy Wilcox from our team. You can go to our website to see our upcoming schedule. So with that, I want to very much thank Renee Broadbent and Bruno Nardone for participating in the event. I want to thank Mirth and NextGen Healthcare Solution for sponsoring, and I want to thank all of you for attending. Everybody have a wonderful day. Thank you.
Thank you. Thank you.
Thanks.